It wasn't in there in the beginning.
So did we still need to go through that one with 125?
Yes, we want to talk about that right now. Those big conglomerates, because I know you got lives, I understand that. I need you to scroll through there before class so you can kind of sort of have a working understanding of what we're going to talk about. But usually if I say there's a PowerPoint posted, it'll be one of mine. And that kind of takes all the information that you need to know and kind of concise, pare it down.
So that's like what we studied for the class.
Yes. So look at those big PowerPoints. Those humongous PowerPoints will get you all the way through fourth block. So don't get rid of them. I don't need those. You do need those. Because they're really not going to go back and go over that stuff.
So do we need to know, like, are you
You'll need to know. Very basic now. Basic. But that doesn't mean you won't have teachable moments in clinical. If you get somebody that got a funky rhythm and they print it off for you, we'll talk about it in a post conference or something like that. So it's very basic. Alright, so I said I was going to show you
That's not it. Yeah, I got it. Oh, okay.
this video.
Oh, you don't know.
Wait.
Do you hear this?
No.
In the cytosol, the sodium ion concentration is kept low relative to the extracellular fluid, and conversely, the potassium ion concentration in the cytosol is kept high. Like water behind a dam,
I've seen this.
these gradients harbor potential energy that the cell taps to fuel cellular work. Animal cells use a membrane pump, called the sodium-potassium pump, to maintain these ion gradients. To begin the pumping cycle, sodium ions enter binding sites on the cytosolic side of the pump. Although there are 3 sodium binding sites on this pump, for simplicity, only one is illustrated here. Pumping sodium against its concentration gradient requires energy, which is provided by cleaving ATP. ATP transfers a phosphate group to the pump in a high energy.
Is it not loaded?
Okay, how this story is really going to end is this is going to go out there, and that's going to come in here, and then it says repeat, and then who is this? ADP? Did that come over there yet? It's going to turn into
It was
ADP.
It was ATP.
So it left one.
Mhm.
All right, and that's how it opens up, and then it goes. You don't have time.
I tried.
All right, I need 4 volunteers right now. I need a left atrium. I need a right atrium. I need a left ventricle.
Ow!
Right atrium.
You're so funny. You're so cute.
He's taller. She's not vertically tall. He's taller.
Get in the right place. So, right atrium. Alright, hold your side right. Alright. Are they standing in the right places?
Yeah.
Alright.
Looks like I'm the aortic arch.
Okay. Now,
Ready volunteering?
I need some blood.
He's
Come on.
right.
Come on. Let's go.
Sasha's smart red too.
Alright, so this blood is coming from where? Where do we say the blood comes from? Venus. Alright.
Showing some resistance, so.
That's correct. So, if we come from the Venus, which way do we go?
To the right atrium.
into the right ventricle.
What's in between here? What color are we?
You guys just go blue.
Alright, so we go through our thing and we turn what?
Red.
Okay. Where do we stop? Where's this?
Atrium.
And then he goes what? Contracts, right? And then we come down here. Alright? Rest, and then we contract again, right? And then where should we go? Okay, line up right there. I need some more blood.
Isn't it really leaving the ventricle, going to the lungs, coming back? Okay.
Yep. Alright, I need some more blood. Come on.
Oh, this blood thing,
Alright, I need some more. We're gonna keep going because I make a point. Alright, so now they're getting ready to go in, right? So we need our heart to contract. Everybody clap, simulated contraction. Clap. Alright. Move. Alright, so we have love, and we're gonna contract again, right? Keep it going. Alright, clap again. Get out. But what happens over here? Where should they go?
Over here.
They should go out, right, to the body. Don't move though. Okay, just move it.
I wanted to come.
No, you can't.
Keep moving.
All right. So our afterload is, what did you just say?
Resistance.
Is resistant to the blood going where?
The bottom.
To the body. All right. So remember that. Okay. I need some more blood. We gonna clap one time, then y'all make y'all way around. Okay. Heartbeat, clap. Go. Where you supposed to be? Come on, you know the heart. Get through there.
Okay, go.
Get go. It's backed up. Where are we starting to have blood?
Left ventricle.
Left ventricle. So what is our left ventricle in control of? Ejection what? Fraction. So that ejection fraction is going to be our force to get all of these guys where they're supposed to be. But somewhere we are meeting resistance. So you notice our blood is starting to back up, right? So we need some more blood. Come on.
So do you want the fraction to be higher? Higher is good.
Higher is
You want
good.
it to be at the water.
All right, everybody that's left, let's clap. All right, circle around. Go where you're supposed to go. 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 Oh, wow. Well, now, what happened to the left side of our heart? It's full. It's a little congested. What is your patient going to look like? Okay, so we had some shortness of breath, some crackles. If you did, they may be pale. They're not perfusing. We're not getting that oxygenated blood. So you two, thank goodness you got on blue because what's probably not happening to them?
Not getting on it.
They're not getting oxygenated. All right, so this person can have, we said shortness of breath. They may be diaphoretic. They may be pale. They may be posturing because they're trying to do what to those lungs? Okay, they need some expansion, some air. It's not air in there. What's in there? Blood, fluid. Okay, so we get some congestion. Everybody that's left, let's go. Come on.
Happy Friday. Or are we like just
Yes, so I'll clap. And you're supposed to go where you're supposed to go. Oh. Okay, so all of our blood is bagged up, right? Because of one something out there. Eventually, if we can't get it out that way, what's going to happen to our freeload? It's going to back up. So right now, we have somebody that's in what sided failure over here?
Right.
How do we know they're in right sided failure? What do they look like? Dependent edema. What else? Jugular vein distension. What's up here? Liver. What is that called? Yes, hepatomegaly, liver engorgement, okay? You may even see some abdominal distension, all right? Somebody can be oh so full of fluid all over their body because you guys are just kind of hanging out all over the place. When someone has that much edema, the big funky term for that is called anasarca. They are full of fluid, what we call third spacing. The fluid has spilled out into the interstitial. It can no longer be held within the cells. Makes sense. This preload and afterload makes sense to you now. Can you visualize it? Understand it? All right, now we're going to talk about how we fix all of this stuff. Okay? All right.
Play 6.
Here's your.
Thank you.
Is there another word instead of that what is that word?
Anasarca,
Is there another word they use in the hospital for
third spacing. You may hear third spacing.
where's the N?
Oops.
It started with an N. They said I would hear it once I got to this part.
Facial edema?
Probably where their whole body is just like full of fluid everywhere.
Anasarca.
Oh, that. Never mind.
Anasarca. It's A-N-S-C-A-R-C-A or something like that.
A-N-A-S.
Alright, this is in your shell now. That's my one. That's below. Alright, so we talked about how the heart is supposed to work, right? SA no, AB no, kidney fibers, all that good stuff. We just did this demonstration of how the heart contracts and does what it's supposed to do, blood is supposed to go where it's supposed to go, but if everybody worked that way, you would not be here, we would not be here, we would not have jobs. So we need to deal with when things go wrong. Coronary artery disease can be a cause of that resistance of the blood getting to where it needs to be. It can be the cause of the heart not being able to perfuse how it's supposed to perfuse and contract how it is supposed to contract, okay? That's what you need to know about coronary artery disease. What is the word sequela? Heard that before. It's a condition as a result of. So if somebody has coronary artery disease, the sequela of that, or the caveat to that, they're going to have decreased cardiac perfusion, hypertension. Would somebody have high blood pressure with that demonstration that we just did?
Yeah.
Okay. Are they going to have a little chest pain? Is our heart going to start beating kind of wonky and funky? All right. Could they not have a heart attack? Heart failure? We demonstrated that, right? If we don't fix it, or they get to us too late, that is your reality. Death. All right. Assessment. Chest pain. What do you want to know about somebody who says they are having chest pain?
What type of pain, where,
Okay, where? What else would you like to know about that pain?
how long,
How long? What else?
their cardiac.
How they would describe it.
How they describe it? Let's not talk about enzymes just yet. Just think about basically if we're assessing them for some cardiac disorder and they're telling you they're having chest pain. You said you want to know when it started. You want them to describe it. What else would you want them to tell you about that pain? What makes it worse or what makes it better? Okay. Palpitations. Why are palpitations important? What is that telling us? If they say my heart's not, it feels like it's palpitating or fluttering. What does that mean to you?
It's a dysrhythmia.
All right, something is wrong with that heart, right? It's not contracting how it is supposed to. Do we know why at this point?
No.
Do we care why at this point?
No.
But we just know that something is not right. All right? Dyspnea, what does that mean?
Difficulty breathing.
Shortness of breath. They're having a problem breathing. Do we want to know that? Would we like to know how long? What else would you like to know about someone who's complaining of dyspnea? All right, we want to know a little more history. Are they tired? Are they tired doing what? What will clue you in something's not really right? What did you say?
Walking.
Walking. What else? Everyday activity. Nobody should be short of breath doing things that they do every day. Brushing their teeth, taking a shower. Okay, those things, those little bitty things. We're gonna harp all semester about the little things. Because if you don't catch the little things, I guarantee you, you won't know what to do when they do code. You didn't understand the connection. So, what about sleeping? Is that not important? If they're orthopnic, right? So, meaning if they lay flat, they can't breathe, what does that mean to you? A lot of fluid. Somebody lays supine, where does that fluid go? All over. It's gonna, if they lay flat, it's gonna, the pressure, the fluid is gonna be right where? Okay, on the lungs, on the heart. Syncope, what does that mean?
Fainting.
Oh, they fainted. Do you really want to know that?
Yeah.
Yes, we want to know that, okay? Hopefully somebody found them. If you can, figure out how long they've been down. You might want to know, has this ever happened before? Because I guarantee you probably did, and they poo-pooed it and whatever. Can symptoms in women be different?
Yes.
You're hearing a lot about that, right? Next month is Women's Heart Health Month, okay? February. Women do not experience cardiac pain the same way. When I went to nursing school, everybody had the crushing elephant on their chest. They had the pain that went up there to their jaw, down their shoulder, and may radiate down the back. Not true. Women, we are wired differently for several awesome reasons. And our pain tract is different also. So, we give more vague symptoms. What things that we're used to? What do you think some of those symptoms are?
Uncomfortable.
Heartburn.
Heartburn. What else? Maybe some back pain. What else? Maybe a little headache. What do we do? Tired. That's the tired. Maybe feeling a little anxious. Right, trouble sleeping. So they kind of poo-poo that, give you some, lorazepam, some Ambien, and send you on your way. 24 hours later, 12 to 24 hours later, some of these women came back. DOA, dead on arrival, because they had had a huge cardiac infarction. Nausea. Tiredness. Indigestion. Nobody should eat Tums for breakfast on a daily basis. No, nobody. For several other different reasons. Okay? Anxiety. Anxiety is something that anyone who's experiencing cardiac problems may have. But just because those things were traditional to women, that's how all of this was misdiagnosed. We lost some very key people that worked at the hospital. And nurses, we are the worst patients, okay? I'm guilty of that. Because knowledge is a very dangerous thing. You think it's not happening to you, and it is happening. So, educate your patients. This is why you need to be educated. What does nausea, indigestion, anxiety, a little chest pain, what does that mimic? It could be the flu, what else?
Pregnancy.
Menstrual cycle, possibly.
GERD, yep. And also, we have to run the gamut of tests to figure it out. So, if sometimes they're giving us all of these indigestion type complaints, we'll give them something called a GI cocktail. But that doesn't mean we don't do our cardiac panels, which we're going to talk about. So, again, remember what I'm saying, you got to keep all these different things in the back of your mind. This is what I'm talking about. If this person came to you, or you're the nurse on medical, majority of my background is ED nursing, but that does not mean when I worked med-surg or floated to tele, I didn't find people like this, because I did. And you still have to know what to do. So So if you found somebody complaining of these things on the most basic level, what are they lacking?
Oxygen.
Oxygen. What would be your first thing to do?
Give them oxygen.
Give them some oxygen, okay? If they are laying flat, what would you like to do?
Sit them up.
Raise their head of the bed up, give them some oxygen, and then go from there. We'll talk about those orders. Is that making sense to you? All right. Why are these color coded?
Things you can change, things you can't.
All that modifiable, non-modifiable foolishness that you learned last semester actually makes sense now, doesn't it? Okay, you know, I learned this. I learned this. Now you know why you gotta learn it. No matter what, you cannot change your gender, race, age, family history. You get what you get. Okay? How you play with the cards that you get, it's up to you. These things all can be changed, can they not?
Yes.
Lifestyle, right? Hyperlipidemia, lay off all that fat food. Smoking, stop it. Diabetes, it can be congenital, right? Or type 2, we're seeing younger people. There's no reason we need to have 10, 11, and 12-year-olds being diagnosed with type 2 diabetes. What do you think they're going to look like when they get 18 to 20? Okay? Obesity. 80-pound 5-year-olds are not cute. I don't care what nobody says. They're not cute. Metabolic syndrome, kind of read up on that in your book. It encompasses kind of like all of these things, but imagine metabolic syndrome on top of hypertension, on top of decreased renal function, okay? And other things that we do to our body. Even though I'm telling you these things, we're really going to talk about how we teach our patients that you can do this, but we really don't take into account where our patients are coming from and things that they have to encounter. And you guys are on the forefront of a whole brand new healthcare system. So, good luck. Diagnostics. Lab. You learned all these, right?
Yep.
What's in your CBC? Okay, so your blood count. We have our white blood cells, our red blood cells, your eosinophils, neutrophils, all those kind of things, right? CMP. What's so special about that?
Metabolic.
Okay, so your complete metabolic panel. I have all the stuff that I need, my sodium, my potassium, my glucose, my BUE and creatinine. What are those labs for? Kidney, all right, your kidney function. PT, PTT, INR, your coagulation panel. Anybody that comes in the ED or you think they're having chest pain, you are going to run this, okay? Your PT is for, your PT and INR go together for a medication called Coumadin. Write that down. Your PTT is heparin. The way to remember that is your two T's kind of look like an H, don't they?
So if your PT and your INR are off, you give Coumadin. If your PTT is
No, those are the labs that you use to measure the levels of your Coumadin. PT, INR is for Coumadin. So anybody that's taking Coumadin, when you go to the hospital, look and see if they have that level drawn. And your PTT is for somebody who could be the potential to have heparin or is currently on a heparin drip. And depending upon those values, you're going to have to adjust the medication that they are receiving. Then we have our cardiac panel. You may hear it as your enzymes. I need to run my enzymes. We have your troponin, your CK, your CKMB, and your myoglobin. I think this is your creatinine kinase, myo something, your myoglobin. This may be something that's done later because it's faster, okay? So after the calm of the storm, then they may throw this on for the next morning. But someone who is acutely exhibiting these symptoms, we're going to do from myoglobin all the way up. Any questions?
So if they're not on any
No,
blood
not yet.
thinner, no, if they're not, do you check the PT,
Yes,
PTT, or
because you have the potential to give those medications. When you get there, you're on the spot. So this is going to be your baseline. All of these are your baseline lab tests. And depending on what our results come back with, that's going to guide the rest of your nursing intervention. Chest X-ray, EKG, sound familiar? CT scan. When I worked in the emergency department at Mercy Gilbert, we had order sets. So someone came in with chest pain, we automatically ordered them a CT scan. And at first I thought, oh, that's a little excessive. But when I thought about it for 5 minutes, it made a whole lot of sense. And this is why. What they are looking for is calcification within those vessels. So if they did not have a heart attack at that time, based on the results of that CT scan, they can look at the heart, they can look at those arteries, and tell them if you don't change your ways, you'll be back in the next so many whatever with a big heart attack. Okay? What they do once they leave us is totally up to them. I'd rather spend that money up front with this thing called prevention than on the back end with this maintenance. There are millions and millions of dollars being spent on cardiac rehab, on things that had we done what we were doing way back when it worked before people started chasing this almighty dollar. Every once in a while I get another soapbox and then I come back down, I promise. We could have a healthcare system that really works. When I was growing up, everything was prevention, and that's how people were living longer and living healthier lives. Now people are living longer, but not necessarily healthier because of scientific advancement, not because of using common sense. So if I can decrease the cost of healthcare up front by giving somebody a $2,000 CT scan, telling them they have 2 years to turn it around, versus having a massive heart attack and having to be on cardiac meds and rehab, or maybe even going to the CHF outpatient clinic for infusions for the rest of their life. What do you think that $2,000 up front is going to compare to if they live for the next 15, 20 years after that cardiac event? So that's what you guys are dealing with. And is it, you guys learn about primary or secondary prevention? Is it both or one or the other? The CT scan. It can be primary, right?
Yeah.
And it can be secondary. Can you have more than one heart attack?
Yeah.
Oh, yeah. Yeah, people go up around here and have 5 or 6 of them. So if we can catch you at the beginning, and hopefully you didn't have one, okay, 2 years from now, Brad, I don't know. Next time you come here, we may be pumping your chest and we'll go out shooting first. But, hey, that's up to you. Ramses, all right, we didn't catch you this time, but you know what? Your calcification levels are horrible. So this is what we need you to do and adhere to this, or you may not even make it back next time. You may be walking out to your car, poop will fall down. It's 120 degrees, no one will find you. Those are the things you want to say. All right. They can have a cardiac cath, percutaneous coronary intervention. When you get to 4th floor class, you're going to go to the cath lab, and you're going to see how they go in and do the dye and all that. But on med-surg and tele, you're on the front end of that. You're going to prepare your patients to go have these things done. So you still need to be apprised of what you need to know, and we're going to do some teaching with that patient. You need to know what's going to happen in there, and what they can expect. Hopefully, they come back to you on the floor. And then somebody who has had a coronary artery bypass graft. We call it a cabbage because nobody has time to say all that in 5 minutes. So if you see someone who has a zipper, that's what we call it, a nice zipper down the chest, you say, have you had these surgeries? They'll say no. Oh, see that scar down your chest? Oh, yeah, back in 75, I had open heart surgery. Yeah, how did you know? They do something, oh yeah, they took 3 vessels and you had no surgery. Okay. So these are the things that you guys are going to have to deal with your patients. Alright. So remember we talked about that action potential and your depolarization and repolarization and love and dove and yada 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 yada. That was the English version, right? Just words. I like pictures because I'm visual. This is what it looks like. At your level, I expect for you to know that you have a P wave, which is your atrial depolarization, okay? Then you're going to have a QRS, which is your ventricular depolarization, so your love, right? And then your T is going to be in your resting space. So you see how this is all nice and cute and compact, PQRST. You can see that, right? This is what a normal heart contraction looks like. Now, this is one thing to go off. Up top, what is that? Normal, PQRST, everybody's happy? All midline? What's that?
It's a high T.
That's bad. Okay, that's what we call a STEMI, an ST elevation MI. Somebody who is actively in the middle of a heart attack, okay? So you see our T wave just kind of whoop, went way up there. That's the heart screaming like, hey, I'm not getting some oxygen. I need somebody to help me. Can you help me? Anybody? Can you help me? Okay? So when you see that, you're like, yes, you're going to work. This is somebody you want to get to the cath lab ASAP. So they have all these protocols in place that somebody needs to be from door to cath lab in so many minutes. I saw it in action when I was at University Gilbert. We had him on the gurney, ready to go from the door to the gurney to the cath lab in 15 minutes, and the cardiologist said, I just looked at his EKG and he's not going to go. I was like, dude, we did this in 15 minutes and you're not even going to take him and say hi? But it was just awesome to see how, because time is muscle. You do not, at this point, regenerate your cardiac cells. Now they have all this research where they're using stem cells to regenerate cardiac tissue. But for us right now, we're not doing that. Your person needs to get to the door, to the back, and to the cath lab, and to whatever clot bluster they are going to give them within that time frame. I think standard is 60 or 80 minutes. You want to try to get to that 60-minute mark, because I'm quite sure if your hospital can do that, that's going to generate some money for you, okay? This one is going to be your non-STEMI. ST depression. They're having chest pain, but I'm not so excited, okay? I'm a little anxious because that doesn't mean they can't go from here to here. This lets me know that they've had some ST depression. Something happened there before, or maybe we're kind of early. Understand what I'm saying? They're kind of early, but I'm still going to watch this person. This is someone that will be on what we call serial enzymes, meaning maybe that first block of enzymes was not like red flags, they're actively having a heart attack. So 6 hours later, we're going to draw another set of those same labs that we drew, mostly your cardiac markers or your cardiac enzymes. And if they raise, then I know that this person here is probably going to transition here, okay? So I'm not, like running around with a chicken with my head cut off, but that doesn't mean I'm not really ready to pull the trigger if I need to.
So for the STEMI, does that mean that the ventricles aren't going back down to depolarization, so they're kind of still contracting at that point, and that's why it's not going back down?
It's not going back down because it's not getting the oxygen that it needs.
Okay.
So it's still working, but at this point, it's screaming to you that I need oxygen. And the reason why it may still be working, there's this thing called collateral circulation. It only works the older you get, so that's one thing Bible says as you get older. Is that you have branches of like little capillary beds and little bitty arteries that may grow off the main branches of the heart. If those can perfuse the heart enough, the heart can still get oxygen, but not as much as it would not to produce that. You know what I'm saying? So collateral circulation has saved many people's lives. It does not work also well if you're young, okay? Because you have not lived long enough for your body to mature and to grow that circulation. So those of you hear of a heart attack that died at like 25 and 30, they didn't have that collateral circulation to kind of help fuse their heart to buy them some time.
Do you only grow that collateral circulation if you have like maybe a partial blockage, or even a perfectly healthy person will develop that?
A perfectly healthy person, but usually sometimes if some blockage is starting to happen, the body, we have an awesome body. It will try to repair itself. So whatever it needs to do to make sure everything is still working until it cannot compensate anymore, that's what it'll do. So it will go either way. I'm sure it comes off. This, notice that your STEMIs dealt with your STs, right? Your T-wave inversion lets me know that this is a past ischemic event. This person has had a heart attack before. Your T-wave is just inverted. It also could mean that if they are symptomatic, so experiencing some chest pain, yeah, I'm gonna watch them. You know, I'm not gonna poo-poo them either. You may see T-wave inversion with if your potassium is off. Makes sense. Alright, cardiac catheterization. This is an invasive procedure. You have two types. You have diagnostic and you have interventional. Most places, if they have a cath lab, usually can do both. Sometimes they can only diagnose and then they need to ship them out somewhere else. Cathogram, within the last 2 years, has now gone from diagnostic to both. They can diagnose what's going on and intervene at the same time, which I think is really awesome in a rural area. I come from a big city, so I took a lot of things for granted when I moved here. Like when the ED overflowed, I'm like, y'all need to divert. We can't divert. Who does that? What do you mean you can't divert? We're the only hospital between here and Tucson. I was like, where? What do you mean? We're the only hospital. Okay? Where I'm from, there are like 10 hospitals in a 5-mile radius. So we needed to divert or close because our ED was busting at the seams. Somebody else could pick up our slack. We didn't have that here. We had a cardiac cath lab. We had a cath team. We could send them across and they would meet the patient there and diagnose them and intervene and send them up to you. We didn't have that here. So you really need to understand where you work, your community, your resources that you have available, and you really need to be keen on your assessment skills. Your assessment skills are really going to save people's lives. So if you can pick up on those little things, and I always think the worst. When I walk in a patient's room, I always think they're going to die. I don't care if they're there for a hangnail. Okay, this person has this. What if they do this? Then I need to be prepared to do this, that. Are you there yet? No. But we expect you to get there one day, 2 years after you've graduated and been working out there for a while, okay? So this is not going to happen in clinical. This is not going to happen overnight, but we're going to challenge you to start thinking that way, okay? So when they go to have this cardiac cath, they're going to look at those arteries, okay? The patency and the extent of the atherosclerosis. What is atherosclerosis? What's that?
Hardening of the
Hardening of the arteries. So all those lipids and fats and all that foolishness that gets stuck in there, okay? So they may or may not have a stent placed to unblock it, okay? And then that turns into your this one here. So the PCI is when they go in and they look around, and then they kind of switch it to this if they have the stents or blocks placed. If they are also occluded, you better believe that patient is on their way to surgery because they are a candidate